Welcome to the State of Data Science in Africa series, which is presented by the National Institutes of Health Common Fund. My name is Maggie Dugan, and I'm here with my colleagues from No Innovation. We're also known as KI, like the KI in Chi-Storm. That's how you got here today. Our team is based in the US and in Europe and in Africa, and we facilitate workshops and meetings and online events like this, all of them intended to accelerate scientific innovation. Briefly, our agenda today is behind me. I'll do a very quick welcome. We'll get to the meat very soon. We'll do a little background on the funding opportunities that are associated with this event and give you some tips for optimizing your experience during the course of this webinar. We'll have an overview of today's session on using health metrics in Africa from our moderator, George Mensah, and then short presentations from each of our four panelists. I'll let him introduce them, and then a short plenary conclusion as well. But wait, there's more. Immediately after the webinar, we'll host interactive topic discussions, and you're certainly not required to join those. It's optional, but we hope you will in order to continue the conversation with the panelists and also to network with others who are interested in the topic of measuring, mapping, and monitoring health data in Africa. Today's event is connected to an NIH program on harnessing data science for health, discovery, and innovation in Africa. I'm going to hand it over briefly to Amit Mistry, who is a senior scientist at the National Institutes of Health, Fogarty International Center, so he can tell you just very briefly about the funding opportunity. Amit.
Thank you so much, Maggie. And I just wanted to remind everyone once again that this is part of the DSI Africa program and new funding opportunities that are currently open for submission. The submission deadlines are coming up in late November and early December. And you can find a wealth of information about the four different funding opportunities at the website shown here, www.bit.ly/NIH-DSI Africa. You can learn more about the funding opportunities at that website. And there also are several resources, FAQs, and networking tools that you can find at that link, but also in Chi-Storm, which is the platform that you use to access today's events. So please keep those dates in mind if you're interested in applying, and please visit Chi-Storm and the website to get more information about the four different funding opportunities that are open. I also wanted to take this opportunity to let you know that this is the last event in our series, but we are planning one final session that will be sort of a closing of the activities over the past few months. We'll be hosting the DSI Africa Landscaping Workshop on December 15th. And this is meant to be a closing workshop to help us look back at the past few months of activities and further examine the state of the field of data science for health in Africa. This final workshop will be a little bit different than the previous sessions. It will mostly consist of small breakout group discussions where we're going to be hearing from you. We're going to have participants brainstorming around several key questions on this topic. And the insights that we gain from this final workshop will be used to inform a series of scientific papers that the NIH is working on for 2021. So because of the different nature of this workshop, space will be limited. We're going to be working to make sure we have a diverse audience in the group, but there will be an opportunity for anyone who's interested to state their interest and let us know that you're interested in participating. We're going to be sharing more information on how the registration process works soon by email, so please stay tuned. But in the meantime, please mark this date down, and more information will be coming by email. Thank you all very much, and back to you, Maggie.
Terrific, thank you. I'll add a little bit more information too. For those of you who are interested in social media, I know that our moderator is especially keen to use social media to get the message out about this topic. So if you do tweet or use Instagram or anything where you use hashtags, here are some I could recommend. We'll put them in the chat as well. Hashtag DSI Africa, hashtag 5M DSI Africa, hashtag health metrics. All right, so just a few other things that I can share with you as we get ready for the panel to start. This session is of course being recorded. I think you can see the recording light, and that will be something that's available to you if you want to look at any of these talks again or hear it. You'll find it on ChiStorm and also on the NIH YouTube channel. If you have any technical issues today, please don't suffer. In ChiStorm, you can scroll down the left-hand menu and find the Need Help page. There'll be somebody there. You can either leave a Post-it note there, or there's a Zoom room that you can go to there, and you can get some assistance to help you get connected to us again. During this program, we really need you to add questions. So please take a look at the little speech chats at the bottom of the screen, and you can click on those and ask questions. That will help feed the panel discussion later on. And if you see a question, you think, I have that question too, or, ooh, that's a good question. I'd really like to see the answer to that. By all means, please upvote it so that the panelists and the moderator know that it's a question that more than one person thinks is interesting. We will answer as many of the questions as we can. We are a large group, so we may not be able to answer everyone, but don't forget there is an interactive breakout session immediately following the webinar, and you can dive deeper with the panelists then and there. So with that, let me introduce today's panel moderator, Dr. George Mensah. Professor Mensah is a cardiologist by training. He has a special interest in global burden of disease assessments. He is currently the director of the Center for Translation Research and Implementation Science at the NIH. George.
Maggie, thank you very much. We've been waiting a long time for this day. So ladies and gentlemen, I want to add my welcome again on behalf of the National Institutes of Health. This is going to be a terrific session. And as I mentioned, we've been waiting for a very long time for it. We definitely saved the very best for the last, and that's why you are here. So this is designed as a session addressing innovations in health metrics, measuring, mapping, and monitoring morbidity and mortality, not just at the regional level, but also at the national and subnational local levels in Africa. There are three main things that would be good to keep in mind for this session. We really want to highlight the emerging field of health metrics sciences and the role that it can play in measuring and mapping health and disease, as well as monitoring and evaluating the summary measures of health in Africa, so that we can better develop and implement measures to reduce the burden of disease and related risk factors. Also designed to identify the challenges and, more importantly, the unique opportunities we have that will be relevant to innovation and harnessing data science in Africa. The second point is we paid real attention to make sure we address the increasing role that health metric sciences plays in informing and prioritizing systems level health interventions and important broad public health related decision making. And finally, we want to make sure we discuss how health metrics and health metrics data science can inform and help evaluate more effective integrated care efforts at the intersection of infectious communicable diseases on one hand and chronic non-communicable diseases on the other, and the rapidly growing burden of these conditions. So without further ado, let me introduce the first of our four experts. We're really delighted to have all of them here. I'm going to just only briefly introduce them one at a time as they give their presentation, and then we'll have an opportunity to have a panel discussion. Professor Ali Muqdad is going to be our first presenter. He's a professor of health metric sciences in the new Department of Health Metric Sciences at the University of Washington in Seattle, where he also serves as Chief Strategy Officer in Population Health. And we've invited him specifically for him to begin our session by addressing the big picture, starting at the global level and looking at how we can use the global burden of disease assessment to get better data for better health. Professor Muqdad, over to you.
Thank you, George, and good afternoon, everybody. It's a pleasure to be with you. Good evening. It's a pleasure to be with you, and I will talk to you about the global burden of disease, better data for better health. The global burden of disease is a systematic scientific effort to quantify the magnitude of health loss due to diseases, injuries, and risk factors. We do it by age, by sex, by time, and by geography, of course, from 1990 to 2019, which was released last Thursday. Basically, you can't save lives if you don't know what people are dying from, and you cannot make people healthier if you don't know what's ailing them. We have about 400 people working on the GBD, different training. So we have epidemiologists, statisticians, demographers, all type of skills in order to make it happen. We have over 5,500 collaborators all over the world, which is very important, a lot of computational power, and we use all data that's available in order to put it together and get an estimation of the burden of disease. For the burden of disease, in addition to the traditional metrics that we use in epidemiology or statistics, prevalence, incidence, and death numbers, we provide several new indicators. First one is years of life lost, which is the number of years lost at each age compared to a reference of life expectancy of a Japanese woman at 86 years old. So somebody in Ghana dying at age 60, he will lose or she will lose 26 years of life. And then we can assign this years of life lost to a cause or to a disease. Years lived with disability is if somebody in Ghana at age 60 got diabetes for 10 years, depending on the severity of diabetes, he will be assigned a disability, and it's called years of life lived with disability. And we can again attribute that to a disease or a risk factor. DALY's, disability adjusted life years, is the combination of years of life lost and years lived with disability. It's basically an overall picture of health, and it's kind of telling all of us what's killing us and what's ailing us in a population, which is very important because some of the conditions cause a lot of disability, such as mental health or back pain, but most of the times they don't lead to death. And of course, we provide life expectancy and healthy life expectancy. We have 7 super regions, 21 regions, 204 countries and territories. And for many countries, we have subnational. In Africa, we have South Africa, Ethiopia, and Kenya. All what I'm presenting is available on the web. All the data sources are available on our Global Health Data Exchange. For every country in the world, you could put in the name of the country, and it gives you all the sources of data that we use in GBD. And everything I'm presenting today is available in a nice visualization on our web that you can mine the data, download the data, and use it for your purpose. So basically, this is the picture for the health of the world. Look at it as a pie chart. Blue here is non-communicable diseases, chronic diseases. Red here is infectious diseases, and green is injuries. And if you look at the globe, for example, here, you could see that infectious disease and injuries are almost 25% of the global burden of disease. Now I'm looking at Africa. Again, this is from our web. If you look at Africa, that's totally different. The largest burden is coming from infectious disease and less so from chronic disease. However, from 1990 till 2019, we see a shift and we see an increase in non-communicable diseases. So that's the causes of death in Africa from 1990 to 2019. By Africa here, I mean Afro, WHO Afro region, not the whole continent. And you could see here still infectious disease, top 5 are leading causes of death. But as you can see, the blue is rising here. Ischemic heart disease, stroke, congenital defects, cirrhosis, diabetes, all of them are increasing. And one thing about Africa, about the success story that has happened in Africa, we need to remind ourselves of that. This is in 1990. This is the number of deaths in the Afro region. And if you look at here, the scale is 1.5 million. Roughly, we're looking about 4 million deaths under age of 5 in 1990. Few deaths coming from non-communicable diseases, the blue later in age. We fast forward to 2019, the scale has changed. So it's now 800,000. A tremendous success in reducing mortality under 5, but still we have a long way to go. But a rise in non-communicable diseases, as I have seen, as people live longer and as the epi transition happens. In GBD, we do something called the socio-demographic index. This is my favorite slide from GBD, which is a combination of fertility, education, and income, GDP. And I am ranking countries here on the y-axis from the lowest SDI to the highest. And then as you can see here, I'm splitting YLL and YLDs. You could see as countries move up in their socio-demographic index, they have less years of life lost. People are living longer and not dying at a younger age. Most of the deaths in low SDI, which countries in Africa unfortunately are there, it's from infectious disease, red. And then as countries live longer, they'll have more years lived with disability because people are living longer with disability. So very powerful slide showing the change and what we call epi-transition. You're looking at it right now. As countries advance and improve their socio-demographic index, their health performance is much better. And it's important for all of us to remember as we tackle health issues to also still focus on the drivers and the socio-demographic index and the social determinant of health. We also at NHLBI briefly, we provide SDGs, health-related SDGs for every country in the world. Here, the red, darker red is the lowest, unfortunately, and you could see Africa is not performing very well when it comes to SDG. On our web, you could mine the SDGs, you could look at your own country and you could pick any SDGs, obesity, HIV, and you could see where you are, where you will be in 2030. We provide something called the health access and quality of care for every country in the world. We do it indirectly by taking certain diseases that people should not die from in the presence of good access and good quality of medical care. Again, you could see the problems here in Africa. Again, available on our web. You could mine the data. We have nice visualization. You could download it. We do forecasting where we provide future health scenarios. And it's very important for us not to look at the burden right now, but look at it down on the road in order to make sure we plan today activities and we focus our limited resources in order to get the maximum return on investment. So we provide you with a future health scenario, what diabetes will be in 2040, and what if we do certain things, what will happen. We also track all the finances. Again, on our web, you could see who's paying for what fund it's going and how it's being spent at the country. We have spending by country out of pocket or what the government is spending. We have more detailed spending in the United States where we have better data on spending as well, but lots of information about the spending. And Laura will talk about small area estimation where we do local burden of disease, 5 by 5 kilometers. And then the last one, which is very important, we do something called the Human Capital Index, which is a combination of education, not only years of education, but quality of education, which we call learning, and a health indicator and probability of dying between ages 20 to 64. So for these four, we create an index, we call it a Human Capital Index, which is very important for us to remind ourselves that investing in health and in education is a main driver for economical development. So if countries want to advance their economy, investing in health and education are key. And all of this is available. Conclusion, GBD as a global good product has become an open global movement for better measurement and better data. We have learned throughout this process, you know, when you get the data and look at it and analyze it, you find if there are problems in it, one. Two, you maximize its utility because we owe it to the people who collected the data and spent the money at the, you know, instead of paying for a vaccination, we paid for a data on vaccination or survey on vaccination coverage. So we owe it to the public to maximize its utility and make it sure it's available for a sound decision, and policy should be driven by data. And the fact that we are doing it on a yearly basis, then you can use it for evaluation. You could see if you invest in immunization in a country, 5 years down the road, what has happened to immunization, because we repeat the same measurement and we do it in a standardized way that allows you comparison over time. It's a useful, comprehensive approach, but again, population health is local. There is data gap and data to policy action. And then we have a lot of shared lesson and technical support that's available if you join us at GBD Collaborate. Thank you, everybody.
Ali, that is fantastic. So thank you very much. I I really, really enjoyed it. You know, the pictures you showed are really powerful. And it's really true that a picture sometimes is worth more than 1,000 words. I also like the emphasis you put on the notion that there are challenges, but yes, there are also opportunities. And I'm hoping that you all are beginning to figure out some of the opportunities and how we can use this in your own research. Please take a minute to put your comments or your questions in the Q&A box. We've saved plenty of time to go over the discussion. So thank you very much. Without wasting any time, I'll move very quickly, introduce our next speaker. Dr. Laura Dwyer-Lindgren is an assistant professor of global health at the Institute for Health Metrics and Evaluation. She's a very vital member of the local burden of disease research team, where her focus has been on mapping and measuring and helping monitor the HIV epidemic. So going from the big global picture and now taking a concrete example you saw in Professor Muqdad's slides, that big red area on that social determinants and social demographics chart that reflected HIV, malaria, TB. And so here, Dr. Dwyer-Lindgren is going to focus on that. And we've invited her specifically to take us from the global to the local and help address the fine scale subnational level variation in health data, how you actually map health and disease. Laura, take it away.
Great, thank you, George. So, you know, as George just kind of set me up for, I'm going to talk briefly about health metrics at a local level, and specifically using as kind of a case study the work that we've been doing mapping HIV burden in sub-Saharan Africa. So Ali just gave, I think, quite a clear overview of the global burden of disease study. So that's sort of the context in which a lot of this work has taken place. So I'm going to talk about the local burden of disease project, which is an extension of the GBD that focuses on fine-scale subnational mapping of selected health outcomes, interventions, and other health-related indicators. So the local burden of disease project, as compared to the global burden of disease study, is considerably less comprehensive in terms of the number of causes that are covered or the number of locations, but it's really much, much more detailed in terms of the geographics, in terms of the locations and the type of geographic detail that we have. And you know, that the reason that it focuses on that is because we have this kind of underlying knowledge that health and disease burden vary within countries among different populations. And one really important dimension in which that happens is by space. And so we want to be able to quantify and display that. So I'm going to focus on our work on mapping HIV burden, but I do want to note that this is just one example of this type of work, and the data sets and the data visualizations for all of the other indicators are available online on many of the same kind of formats that Ali has already alluded to, including data sets on the GHDX and visualizations on our VizHub. So the goal of the analysis that I'm going to be talking about was to leverage existing data to produce reliable, timely, local level estimates of HIV prevalence, incidence, and mortality in sub-Saharan Africa. So we did no primary data collection for this analysis, but in partnership with our collaborators, we did a substantial amount of secondary data collection to see what we could do with what was already available. And broadly speaking, we identified and then utilized 3 bins of data. So we made very extensive use of seroprevalence surveys, so using national level household surveys, things like the DHS surveys or the FIA surveys that also include HIV testing among respondents. We made use of sentinel surveillance data from antenatal care clinics. That's sort of the classic source of data on the HIV epidemic, particularly in sub-Saharan Africa. And then we used data on the reported number of people living with HIV who are on ART by district and by year where those data are available. And those are data that are typically routinely collected as part of service delivery by health systems. So really briefly on the methods, we took a 2-stage approach to get to our estimates at a local level of HIV prevalence and then HIV incidence and mortality. So in the first stage, we estimate HIV prevalence using geostatistical models. The statistics here is fairly involved, but the concept is simple. So from the data sources that I just listed, we have observations of HIV prevalence in some locations and time periods, and we build a model that observes the relationships among those data and those locations and time periods and use it to predict for all locations and time periods in kind of the study area. And then as a second stage, we use epidemiological models known as compartmental models in order to estimate HIV incidence and mortality based on our modeled trends in HIV prevalence. And the idea here is that at a local level, data on HIV incidence and HIV mortality are very hard to come by in most locations in most time periods. So instead of modeling them directly, we rely on the known relationship between HIV incidence, HIV prevalence, and HIV mortality, and the way that that relationship is modified by the presence of ART in order to back out trends in HIV incidence and HIV mortality from what we observe in terms of prevalence. And for those of you who are perhaps familiar with this space, this is fundamentally a pretty similar methodological approach to how national level estimates of HIV burden are generated, but it's been adapted in this case to work well at a local level. So I'd like to show just a few findings from these analyses to kind of illustrate these types of outputs, again, focusing specifically on HIV, and in this case on HIV prevalence. So this is published work. There's a paper in Nature that came out last year describing the methods and findings in a lot more detail if you were interested. And again, these data are available online as well. The figure on this slide is the first of two that I want to discuss. So this shows our estimates of HIV prevalence in 2017 at increasing levels of geographic disaggregation. So as you move from panel A in the upper left to panel D in the lower right, you go from the country level to the state or province level to the district level, and then to estimates on a grid that's approximately 5 by 5 kilometers. And so I show this to highlight a point that I kind of alluded to earlier, which is that there are substantial differences in burden, not only between, but also within countries. So one way that we can quantify that is to say that most of the countries shown here, so 36 out of the 47, had more than a twofold difference in prevalence between the district with the lowest estimated prevalence and the district with the highest estimated prevalence. And then there was 14 countries where that difference between the lowest and the highest observed among districts was more than fivefold. So really substantial and substantive differences. Another way of thinking about that is that within countries that have relatively low prevalence, we nonetheless find areas that have much higher prevalence. And in countries that have relatively high prevalence, there really aren't any areas that are genuinely low prevalence, but there are some areas that are much more substantially impacted than others. So the situation on the ground really varies depending on where you are specifically. And, you know, I don't think that this is a surprise. In many ways, it's not really even a new finding, particularly for HIV, but it is a more comprehensive way of quantifying and describing this phenomenon. And again, just underlies the idea that different areas and different populations have different needs. So this is the second of the two figures that I want to share, and this shows our estimates of the change in HIV prevalence since the beginning of the century, so from 2000 to 2017, and again contrasts the view if you're looking at the national level to increasing levels of geographic disaggregation. And I think the most striking difference that we see here is that there are many countries where we find areas where HIV prevalence has increased over this period, and other areas in the same country where HIV prevalence has decreased. So when you look at the state or the province level, this is true for 16 of these 47 countries. When you look at the district level, this is true for 20. And when you look at this gridded level, this is true for 28 of the 47 countries. So, you know, it's worth saying that with no other information, you can't immediately conclude whether an increase in prevalence is because incidence has increased, which is something that we all don't want, or because mortality has decreased, which is something that we do all want. And so this is not a moral judgment about places that are doing well or places that are doing poorly, but rather is meant to highlight that if you assume that the trends that are playing out at the national level are playing out at all of the local levels within that country, you're getting it wrong in a lot of places. And also, moreover, that because there's places within the same country that are going in opposite directions, the situation on the ground is evolving pretty rapidly. And so it's important to have up-to-date information to stay kind of current with how the situation actually is. So before I wrap up, I'd like to talk about some future directions. And this is intended quite broadly. These are not all things that I personally or our group will be working on, but rather where I hope that researchers generally will go, and many are already going with this type of work. So first, we've made substantial progress on increasing geographic detail, and I hope that I've done a good job demonstrating why this is important. But there are other dimensions of detail that would be useful in concert with geographic detail. So for example, if you think about kind of in the HIV space, there is certainly demand for these types of estimates disaggregated not only geographically, but also by age and by sex or by diagnosis status. Again, thinking in the HIV space, there's demand for other types of indicators. You can imagine things like diagnosis rates, treatment, and viral load suppression in keeping with the UNAIDS 90-90-90 targets. So there's all sorts of additional types of detail, but the key here is doing that at the same time as having the local level of detail. Second, I think that there's really enormous scope for figuring out how to use other types of data for this research, and in particular, figuring out how to use effectively the vast amounts of data that are collected administratively by governments and health systems on a routine basis. So this is inherently way more difficult. You're working with non-random samples, so the statistics get really hard. There's all sorts of potential biases to consider. That just makes everything hard, to be honest. And possibly the biggest challenge is just figuring out how to align across different data collection mechanisms and systems to produce comparable estimates that tell a coherent story. But I think despite the fact that this is quite difficult to do, the potential payoff here is really huge, both in terms of improved estimates or potentially enabling us to do more detailed estimates, but also improved trust and buy-in from the folks who are kind of most immediately involved in collecting these type of data in the first place. So third, these type of estimates clearly highlight important differences. In many cases, I think they highlight inequalities that really demand redress, but by themselves, they don't answer the question of why. So why do we see the patterns that we see? And I think that they can be very useful for hypothesis generation and potentially for testing potential theories, but that does require an additional layer of work well beyond the estimation itself. And this is something that people certainly are working on, but I think it's an area that requires more attention. And then finally, along similar lines, these types of assessments clearly have the potential to be useful in terms of policy and action, by providing a more nuanced view of burden, highlighting inequalities, providing a mechanism for monitoring over time and so on. But there are gaps between the types of insights that these data provide and then identifying the optimal mechanism to act on these insights. And so I think research to identify those mechanisms is also really key here. So with that, I want to wrap up by thanking the organizers and the moderators for inviting me to participate in this panel, which has been such a pleasure, and also to all of you for your interest in this topic.
Dr. Dwyer-Lindgren, that's fantastic. So thank you very much. I mean, seeing is really believing. Some of these maps are truly powerful. And to see a 5-fold difference of disease burden in one country, I mean, what's causing it? How should it inform our interventions and our policies? So I'm glad that you ended by giving people ideas for future directions, and hopefully everybody is thinking about them. Please take a minute to put your comments, your suggestions, your questions in the Q&A box so that we would begin addressing all of them. So in these first 2 sessions, we've gone from the big global picture all the way down to local level using the example of a typical prototype infectious disease. We're now going to give you something that bridges the infectious disease world with the chronic disease world in a way that HIV also does. So it's a real pleasure to welcome Professor Anna Olga Mukumbi. Professor Mukumbi is, I'm looking for my on mute button here, but she's head of the non-communicable disease division in Mozambique's National Health Institute, in addition to her role as professor of cardiology in the Faculty of Medicine at the Eduardo Mondlane University. Now, we've asked her to specifically use what we've just heard from Professor Muqdad and Dr. Dwyer-Lindgren to address the global and local burden of disease as it applies to measuring, mapping, and monitoring rheumatic heart disease. As you know, rheumatic fever on one end, rheumatic heart disease, and the crucial role it plays in morbidity and mortality in Africa. Professor Mukumbi, take it away, please.
Thank you for inviting me first for this exchange. I consider this a knowledge exchange, in fact. And I'm happy to be with all my panelists here and to discuss with you all rheumatic heart disease view in the perspective of the 5 M's, measuring, mapping, and monitoring morbidity and mortality with specific focus on Africa. So I have no disclosures. And to start, I will share what is the current situation of Africa in terms of data, giving the example of what we have for rheumatic heart disease, which is one of the areas where most actively researchers have been investing in the continent. So if you look on your top left, you see that the African continent is the one that has most of the burden on rheumatic heart disease compared to its population, because probably very linked to the fact that it has a high proportion of poor people, people among the poorest billion. And this is important because poverty is one of the determinants for rheumatic heart disease. This is a poverty-related disease. And probably this is why also Africa is taking the lead in trying to fight this disease. So the Pan-African Society of Cardiology, the World Heart Federation, and most recently the WHO have come together to try to eradicate this disease. However, data are not available as much as we would like, also linked to the fact that this is a neglected disease. It has been a neglected disease, and only recently a lot of efforts have been made to clarify some of the unclear issues on its pathogenesis, on its diagnosis, and on its management. So rheumatic heart disease as a complex starts from rheumatic fever, which in turn results from a sore throat. It's not up to now very clear if it's just sore throats caused by group A streptococcal infections, or if the skin infections also have a role to play, mostly in Africa, where the rate of skin infections is extremely high, many times linked to scabies. Part of the people who have untreated sore throats develop rheumatic fever. It's thought that it's around 1 to 3%, and unfortunately, it's not possible to identify those susceptible. And again, lack of treatment and adequate care for this rheumatic fever, which is a febrile condition that can be misdiagnosed and has a differential diagnosis with several infectious diseases in the African continent, can then develop rheumatic heart disease. So from one infectious disease at the beginning, we end up with a chronic disease that is very complex and can lead to need of surgery and very complex treatments in adulthood and in adult life. Unfortunately, several areas need clarification. The susceptibility, the natural history, the pathogenesis, the lack of a pathognomonic test for the diagnosis, and the management of this condition. Finally, although preventable, there are several areas where it's not clear how the secondary prophylaxis acts. The three following slides are busy, and I'm not expecting you to read them. They are there just to show the complexity of one, the diagnosis of rheumatic fever that you see on the slide, which includes epidemiological criteria, clinical criteria, and laboratory criteria, and requires a knowledge, a high sense of suspicion to make the diagnosis. Secondly, you have the screening of rheumatic heart disease, the complication of rheumatic fever, which also requires expertise and technology. And as I show, even the standardized criteria from the World Heart Federation require a lot of thinking, and there is unclear borders between definite and borderline disease. Finally, rheumatic fever and rheumatic heart disease management, it's a very diverse and dynamic field. So you have to treat from the sore throat to surgery and complications of heart failure on one hand, and on the other hand, depending on the group of patients that you are looking at, either pregnant woman, woman in the puerperium, young children, adults, you have several factors that can change and interfere with the treatment. And as I try to show here, on the treatment, you have several goals that have to be reached. And on prophylaxis, you have also different goals because it's a disease across the lifespan. So for those who are interested in doing research and investigating a disease, rheumatic heart disease is a very good example. Unfortunately, we do not have a lot of data, let us say, in the global burden of disease, for instance. We have some, but with this complexity, you can see how much more data we would need for the different stages of the disease. So measuring, it's important. And I would suggest people investing on measuring to address the lack of epidemiological data, basically on the role and the burden of group A streptococcal infection related to rheumatic heart disease and rheumatic fever. First, maybe we can discuss about aggregation of data. We can discuss about developing electronically supported screening and prediction tools to improve and facilitate the diagnosis. We can discuss the use of biomedical imaging, mainly echocardiography in endemic areas. That's what's more available. But even there, try to find ways to explore machine learning-based schemes that can facilitate the diagnosis by people who are not experts, who are not cardiologists. Secondly, I would suggest mapping, one of our 5 M's, because information is crucial here for policymaking, but also to improve care. And for our endemic areas in Africa, another area that is very important is decentralization. With the lack of human resources trained and specialized, decentralization is key, and task shifting through probably the use of supported prediction, of electronically supported predicting rules, risk calculators, use of mobile tools for diagnosis, use of algorithms that can be taught using telemedicine, telediagnosis, standardized surveillance tools that can be shared by several countries or several areas. All this is important for decentralization, and expanding research to other high-risk groups, because now we have been concentrating our research on school children, but as I'm trying to tell you, it's a disease across the lifespan, so we have several other high-risk groups, one amongst them pregnant women, because rheumatic heart disease is probably one of the most important indirect causes of maternal mortality. Monitoring morbidity and mortality, and it's a way to bridge knowledge gaps that exist in prophylaxis and management, and global registries, data on penicillin, improving ways to deliver penicillin, disease-specific clinical trials like Invictus, trying to bring the new anticoagulants to the area, e-supported surgical training and distance learning, and innovation in materials for valve replacement are important. On your top left, you see from Peter Zilla in Cape Town, one sample of a new valve that is trying to come to the market and does not need anticoagulation. So to end, I will try to tackle future direction. So I would say that we can improve our knowledge by using data that is already available, by aggregating the several databases that we have to improve our measuring, mapping, monitoring of morbidity and mortality, aiming to bridge the current gaps in knowledge, improve care and support policy. And I've listed biomedical imaging, use of mobile health, electronic databases and screening tools, aggregation of global data on incident management of outcomes and prophylaxis for penicillin, risk calculators using artificial intelligence, risk calculators and prediction rules, as well as the use of technology to improve prophylaxis, which is a problem, and management, like surgery and anticoagulation. I will end here and thank you all very much for your attention. Over to you.
Excellent. That's wonderful. Thank you very much, Professor Mukumbi. You've really made the point that what gets measured gets managed and it gets done. So let's take it away from there. It's really a great pleasure to introduce our next speaker, Professor Mayowa Owolabi. Professor Mayowa Owolabi is the Dean of the Faculty of Clinical Sciences at the University of Ibadan in Ibadan, Nigeria. He's also the Pioneer Director of the Center for Genomic and Precision Medicine and one of the key leaders of the NIH-funded H3 Africa effort. Now, we've asked him to bring this session to closing by specifically addressing how we use what we've heard to tackle and overcome the major challenges of chronic diseases, specifically stroke and other cardiovascular diseases in Africa. So please take a minute, put your questions, your comments, your suggestions into the Q&A box. And right after Professor Mayowa finishes, we'll bring my colleague, Professor Makeda Williams, to help us address those questions you've already put in there. So please don't forget your questions. Mayowa, take it away, sir.
Thank you very much. Well, this afternoon, I'll be talking about data, using data science initiatives to improve the metrics, that is the measurement, and of course, intervention that will help to reduce the burden of stroke and other cardiovascular diseases on the African continent. We'll be examining what the challenges are, as well as what the opportunities are, and how we can leverage the opportunities to provide pragmatic solutions, population-wide solutions that will actually drive down the burden. I have no disclosures. But in terms of what is available on the African continent for cardiovascular diseases, particularly stroke, and of course, hypertension, obesity, and so on and so forth, well, most of the data that we have are from the Global Body of Diseases. Thanks a lot to the Global Body of Diseases group. There are really other sources, and this covers quite a lot of areas, including causes, risk, impairments, the measures, and metrics across years, showing trends, and across age groups, gender, and different locations, including subnational locations. And indeed, looking at some of the data, you will notice that cardiovascular diseases, including stroke, is now the leading cause of death on the African continent as of 2019. So it's a major challenge that we need to combat. But again, what are the challenges with the data that we have, particularly from the African continent? Well, there is non-availability of high quality data. And in fact, some of the GBD estimates have no choice but to use low quality data from LMICs, including African countries. The sparsity of census data, and in many places there are no vital registration systems, and of course estimates are sometimes indirect, and many times they are also not nationally representative. So there is really a very, very big room for improvement. And of course, data science, mobile technology may be the way to go to assist us with this. Let me just illustrate very briefly. Looking at stroke incidence data from across several African countries and across even globally over several decades, you will observe that in fact, Africa has no rigorously determined and real-life concrete data on stroke incidence. Of course, there are GBD estimates which may be not exactly reflective of the current situation. Of course, there are uncertainty intervals which are published along with GBD interval estimates, which can help. So there is actually a paucity of data on cardiovascular diseases on the African continent. This is just an example. So for stroke, of course, no rigorous incidence studies are lacking. Surveillance registries are also lacking. And more importantly, multi-omics and genome-wide association studies are also not present. These are needed to be able to characterize and quantify the contributions of genetic, multi-omic, and environmental risk factors to the propensity for developing stroke and other cardiovascular diseases on the African continent. It is only by so doing that we can indeed come up with policy statements or interventions that can help turn the tide of non-communicable diseases on the African continent. We came up with the concept of the stroke quadrangle, and with these you will see that the pillars of the quadrangle, which includes health promotion, disease prevention, acute care to reduce mortality, rehabilitation and palliative care, all of these pillars are dependent on epidemiological surveillance. And this is where data collection, rigorous data collection, to understand the burden, to track the burden, to understand the determinants of disease, be it genomic, transomic, or environmental, is extremely important. Because this is very key to planning and designing interventions, and in fact, monitoring the impact of those interventions across the African continent. Well, from the Asia Africa Consortium, the largest study of stroke on the continent, which is SIREN, we're able to identify the key risk factors driving the epidemic of stroke on the continent. And these risk factors will definitely need to be targeted to bring down the burden of stroke on the continent. Well, how do we go about this? One of the key things we found was the protective effect of green leafy vegetable. If this is consumed, multi-sectoral intervention, for instance, would be required, and more people need to know about this. So stroke is just one of the problems. The population at risk of stroke and other cardiovascular diseases is very huge, and primary prevention is very critical. And this again depends on accurate and adequate data. And this also depends on understanding the entire spectrum of cardiovascular diseases that are driving the burden of stroke and other complications. Hypertension, diabetes, dyslipidemia, obesity, and the SHARE consortium is helping us to do this. And we already have some publications from this, examining these relationships across different cardiovascular diseases. So what more do we need to do? Well, we need to understand the interaction between genetics and environment to be able to come up with precision medicine interventions that would help to bring down the burden of stroke on the continent and other cardiovascular diseases, identify new biomarkers, new molecular targets for treatment, precision medicine, and to tailor environmental exposures. This requires genomics, transcriptomics, epigenomics, metabolomics, and bringing all of these together, analyzing all of these together using data science tools to come up with a better understanding, a clearer understanding of the underlying disease pathology and molecular targets that can be targeted to bring down the burden. So what can we leverage? We can leverage the existence and the penetrance of mobile phone on the African continent, which is about more than 80% in most places, to collect new data. On exercise, for instance, on lifestyle, smartphones, wearables, they can all help with this. But also more importantly, we can harness mobile phone technologies for surveillance, and in fact, for improving literacy and education, motivational education that can help with lifestyle changes. So for surveillance, for prevention, and in fact, also for early detection, early presentation to facilitate this, for timely management, promoting acute care, and of course, improving literacy through social media and educational programs, both for the populace as a whole and also for task shifting for health workers. It is extremely key to explore mobile technologies. Well, to be able to come up with these mobile technologies, we need data science to determine the causes as well as the pathogenesis, and of course, the trend and the information that can then be used to develop interventions that can be used or deployed through mobile technologies. Examples of such mobile technology interventions that we may consider and in the works includes the Afrocentric stroke riskometer, by which an individual may be able to quantify and track his own risk of developing stroke. And this could help in motivation as well as lifestyle change to help to bring down the burden. Then Afrocentric stroke outcome evaluation algorithms. And again, we can do event reporting through mobile phone technology for e-surveillance of stroke and other cardiovascular diseases on the African continent that can further enrich the data, the quality and quantity of data that we are collecting to track non-communicable diseases on the continent. And so we'll be able to improve the quality, the quantity, and of course, reduce the uncertainty intervals and increase the data density. And of course, have better evidence that can help to drive pragmatic solutions for policy. So this should be done in the context of working with other implementation partners, so that we are not just measuring and mapping, but we are also providing solutions. Like we said, mapping also helps with management. So we are providing solutions, working with implementation partners. And these implementation partners will include practitioners, providers, physicians, policymakers, patients, payers, and of course, the entire population whom we can reach through social media, through the mobile phone technology. An example of this is the Global Stroke Control Observatory and Burden Reduction Ecosystem, the GSCOR, which we are setting up with the World Health Organization, World Stroke Organization, Lancet Neurology, and the African Stroke Organization, which we are actually going to be launching tomorrow. So working together, we will not only succeed in measuring and tracking the burden of stroke and other cardiovascular diseases on the African continent, but indeed in coming up with pragmatic, evidence-based, technology-driven solutions that can be deployed population-wide to drive down the burden of cardiovascular diseases on the African continent. Thank you so much for this opportunity. We'll keep talking and we'll keep doing what is required to reduce the burden of stroke and cardiovascular diseases on the African continent.
That's wonderful. Professor Owolabi, thank you very much. Before we move into the session on the questions and answers, I'll remind you, please put your last minute questions in the Q&A box. And we would have my colleague, Dr. Makeda Williams, help moderate that session. Let me just quickly check with Maggie and Joe and everyone. We're really doing great. I want to thank all the panelists for staying on time and saving us plenty of time for questions. Dr. Williams?
Thank you, Dr. Mensah. I just want to say before I go into the questions, this is such a great session, and I thank all of the speakers for their wonderful presentations. We really appreciate all your hard work and just bringing this issue to light, which is so important on how we address the burden of NCDs by leveraging health metrics and data science. So what I'm going to do now is just go into the Q&A and talk and ask some of the questions to the speakers that you all have put in. And as Dr. Mensah mentioned, if you could just put your questions, comments, anything that you'd like to share with the speakers, please go ahead and do that now. So I'm going to start with the first question that I see. And I think this is to Professor Makdad, but I think anyone else, any of the other speakers can answer. How do you view opportunities to leverage these small area estimates or local burden for use in social and health determinants? So beyond mapping, how can these be harnessed for studying exposure response relationships, or are there uncertainties around these estimates that are too problematic for such work? So that question came up, Professor Makdad, when you were speaking, but any of the other speakers, if they'd like to chime in, that would be great.
So thank you. I'll start, but Laura will, this is Laura's area. In general, what we do with small area estimate is looking at the differences, especially within a country, and looking at the trends. And the idea here, if you look at a location and look at their variables that determine the founder, like social demographic index and others, and you rank these locations on that level and see which one is doing better against all odds and which one of them is really not improving where it should improving. This will raise a lot of questions, and then you could look at the epidemiology of it and see why this is happening. So it raises these questions that are very important for us to know what is driving this change against the odds or with this odds. And that's very informative for policymaker. That's one. Two, you could, you have limited resources. You know where the most need is, and you go and invest in that area in order to bring it up, because that's the best gain you could get if you bring those who are at the lower level, bring them up rather than focusing at everybody at the high level. Equity in health, that's very important. Laura will answer the question about how solid and how valuable this information, because she has developed a mechanism to validate what she does. So I'll pass it to Laura.
Yeah, thanks, Holly. I mean, I think that this question, reflects an important thing, which is that the estimates do have quite a bit of uncertainty. That's particularly true for causes or indicators where there are less data. And that's particularly true at the very, very granular levels of geographic disaggregation. So, for HIV, which I showed, there's I would say a moderate amount of data sort of in the universe of things that we attempt to map. It's probably right in the middle. And the estimates, when you look at that kind of 5 by 5 kilometer grid cell level, have very wide uncertainty. They have narrower uncertainty when you look at estimates at the district or the province level. I don't think that that's a deal breaker in terms of using the estimates in kind of secondary analyses with other variables. It's just something that needs to be kept in mind, certainly. I would also say that I think that there's a lot of opportunity to leverage the estimates. I mean, keeping in mind kind of the limitations that around uncertainty, to look at the relationship with other variables. I mean, both in the ways that Ali just described, but also in terms of just kind of scientific questions of what are these relationships. Again, it's worth thinking about kind of what the limits are there. So, if you're comparing a particular health outcome at, let's say, the district level to some sociodemographic variable at the district level, you can't, via that analysis, disentangle is whatever relationship you're observing there about the composition of the population versus kind of the context of the population. There's an ecological bias issue, but just, to what extent are these things related at an areal level is very much fair game, and I think a very interesting question for a variety of reasons.
Dr. Williams, let me follow that up with a very quick question. I mean, obviously the social determinants of health are so crucial these days, but how robust are your data sources? I mean, I suspect that education may be a little bit easier, income may be a little bit easier, but how do you address social deprivation, community level social determinants, and the data sources that you use?
Yeah, I think that's a great question. So for the mapping work and thinking specifically about Africa and probably most specifically about sub-Saharan Africa, the data on education are probably some of the strongest. And that's a function of there being a lot of data on education because it's something that's collected not only in surveys, but also in censuses. And so there's just, plentiful data on that kind of relative scale. Income is trickier. It's not actually something that's been mapped large scale yet. However, you can use kind of proxies for, development or urbanicity more broadly to partially kind of cover what you might otherwise be covering by income or wealth. One area that's not quite sort of on the edge of the socio-demographic, but is really critical more generally, that I think that there's more uncertainty about than most people recognize, is actually when it comes to the population estimates. So, population estimates underlie everything that we do. I mean, you can measure how much burden there is in a population. If you don't know how many people there are there, it's sort of difficult to contextualize. And population estimates are weaker than they should be globally. And that's particularly true in countries that for one reason or another haven't had a census in a long time or don't release detailed census data. So I think that's actually an area that deserves more attention.
Great, thank you.
George, that's a very important point. We focus on the numerator in all our work, and that we need to remind ourselves that we need to invest in the denominator.
Good point, good point. Dr. Williams, over to you.
Sure. So another question that came in was, wondering whether the Global Health Data Exchange has the capacity to overlay migration patterns on the changes of disease burden from one time to another. So again, that question came up early in the session, but any of the panelists, please feel free to address this question.
I don't know what the question means by overlay, but when it comes to migration data, we take all what we have and we use it because it has an impact, especially like if you look at a country like the US, immigrants coming here tend to be healthier, and then people moving within the United States sometimes for retirement, depending on age. And also to add complexity to it in the global burden of disease, you have migration and refugee. Look at what's happening in Syria, moving to Jordan, Lebanon, and Turkey. So there are a lot of things that we try to assess in GBD, and sometimes we don't have the adequate data on migration or refugee. And we use what we call in global burden of disease a shock, where we say we know from previous history when this happened 5-10 years ago, and then eventually we knew what has happened, we can assess what was the impact of that event to some extent. And we use it in our modeling right now, and we say, hey, here, it should go up because we know there has been an event in Syria, so infectious disease are going to come up, chronic disease are going to increase a little bit delayed. So when we have the data, we use it. And Global Health Data Exchange, there are some surveys that include migration and immigrant, but I don't know what it means overlay. Happy to discuss it by email with whoever asked the question.
Yeah, that's great. Dr. Williams, could I chime in with a question?
Sure.
Professor Mukumbi, I was really intrigued by your comments on innovations, for example, involving smartphones. And one of the challenges we've had for a long time is even the basic screening data on rheumatic fever, sore throats, that could potentially be big problems in the future. Do you potentially see the feasibility of using smartphones to play a role in screening and data collection? I mean, even most of Africa, all the school children have smartphones. they may not have state-of-the-art smartphones, but the mobile use is very prominent. How could we leverage this to advance the data science and the data collection?
Thank you very much for the question. And I will also add a little bit to the previous questions. I think that also, even in tackling the migration and data for the global burden, there's also opportunities in Africa to use technology and mobile technology, mobile phones in general. Although the rate of smartphones is low, the rate of users of mobile phones is increasing a lot. And we have been using progressively more in care and in research. So I would go back and say that even in Africa, we should experiment to improve the quality of data that is then used by the global burden, even in small models in areas that have particularly moderate usage, and try to involve the communities in data gathering. So coming back to your question, I mentioned, and Professor Mayowa also mentioned briefly, the self-reporting is something that we have been increasingly using because people are interested in their health. Although they are not as literate as we would like them to be, they are interested and they participate very well in reporting events and in reporting outcomes. And even if it's not a smartphone, they are reachable now because we can ask them to tell us when X or Z happens. And this serves as a way to have most of our vital statistics, in fact, in our clinical trials in Africa. In my experience, at least, it works very well. It can take a week because people have their own ceremonies, etc. But then they will call you and tell you that the person is deceased, a new baby is born if the woman is involved. So I think that we should believe and we should try to invest in research in this area.
So this is Makita. I have a question kind of following up on that. And this is for all of the speakers in terms of how you build capacity around conducting data science research within Africa. And also, as Professor Mukumbi mentioned, leveraging the use of smartphones. What are some strategies that you all think could be very helpful and very innovative to really try to increase and enhance the use of these type of technologies and this type of measurement within Africa to build capacity in Africa? And I'll start with Mayowa. I'm just picking someone to start with.
Yeah. Thank you very, very much. I think that's extremely important. As has been said, it is critical to leverage the resources that is available. One of the resources that is readily available is mobile phone and social media. I mean, it's being used for all sorts of things, for politics, for agriculture, and why not use it for health? we can use it for so many things as far as health is concerned, including not only data collection, and by data collection, that may include diet, that may include lifestyle, that may include even event reporting or disease reporting, or in fact, reporting deaths, reporting new births and all of that. But more importantly, it can actually be used to educate and improve literacy about various diseases. So it's an extremely vital tool that we can use to practically change the world, so to speak, by developing the right content, which sometimes may just be graphics, may even be cartoons, in different languages that can educate and that can motivate and can be linked to other resources, both resources where data can be collated and resources where information can be given or where people can be assisted when they have emergencies and so on and so forth. So it's a major system, that can be leveraged by connecting it with other resources, and people will then realize the importance of it. So it can be used for mapping, for monitoring, and for intervention. Now, in terms of capacity building for data collection and for metrics, and even for research, yes, there are different levels of data we might want to collect. In fact, some of it, as has been mentioned, like self-reporting, you can even collect by training people to self-report and using point-of-care devices. People can measure blood sugars. Many households now have automatic blood pressure monitors. So many things. People can measure their weights, they can measure their height, and they can tell you about their BMI or waist circumference, or even their dietary habits and things like that. So you can actually collect some data using that tool, and that's about teaching people so that you can collect it in an accurate and standardized manner. And you can then, for other sophisticated data like multiomics, transomics, and genomics, biorepository science, population cohort studies, and all of that, you also need to set up structures that involve researchers, and you need to also train a crop of researchers, PhDs, postdocs, that can anchor this research. You can link them up initially with successful such facilities in the Western world, with the focus of eventually domesticating data collection, analysis, interpretation, and utilization. And this can be developed over time. And I think this is already happening. Asia Africa has helped with this. DSI will probably also help to reinforce this so that some of this data can be collected, processed, stored, and interpreted on the African continent and utilized, on the African continent. And people would actually over time see the impact of this, including policymakers, and they might also be able to invest locally into collecting this when they already see the benefit of this in driving decisions and improving the health of their people and economy also even of their people. Yeah.
Thank you so much for that. I'm going to ask the other speakers just to make sure we keep with time. So I'll turn it to Laura. Laura, if you have any thoughts about capacity building for health metrics and data science research in Africa.
I think that one thing that is certainly not the only solution here, but is important and part of the solution, is sort of transparency and sharing around what has already been done on the research side in this space. So, in terms of just like how I've been educated in health metrics, I've benefited greatly from the kind of accumulated knowledge that already exists, and particularly when people are releasing their data, releasing their code, being very explicit about their methods and how they arrived at the types of health metrics that they're presenting. And so I think that, that it's, again, not like sufficient in and of itself in terms of capacity building, but perhaps a necessary condition is around kind of sharing that knowledge, or at the very least making that knowledge widely available so that it's accessible for people who are interested.
Thank you. Yes, that is definitely a good point. Professor Anna, you look like you want to say something, so I'll turn it to you.
Thank you. Thank you very much. I just wanted to add that also with the COVID pandemic, a lot of previous taboos that we had were overcome in weeks. And one of them was the fact that we could not do research because we stopped our research suddenly. And then we thought very quickly on what to do. And for instance, the phones were used extensively to continue clinical trials and continue our touch, to keep patients and to keep people who are part of the studies in touch. So I think that it's one opportunity out of the chaos that the pandemic has caused. And I think that one system that we sometimes miss is using the community. Investment and small investments by the community are very important. And they may be systems that can collect data and serve the community through tablets. For instance, we trained community health workers and we gave them tablets to report on the stage and the situation of our chronic patients, for instance. And it was a very small project, but one that worked very well. And in terms of capacity building, it's very good because we discovered through the pandemic that it's a good way to keep in touch with the community health workers, to supervise them and to train them continuously. So I think that we have to think, of course, we have problems of network. Not everywhere they are able to transfer data to you, but they collect and they can do it offline. And nowadays, more or less, for instance, in Mozambique, in every district, you have satellites, so you have ways to transfer offline.
Yeah,
Thank you.
That's definitely a good point as well. And finally, Professor Makdad, I'll turn it over to you for just the final answer to this question about building capacity for health metrics within Africa. Thank you.
So I have 2 quick points I want to make. The first one, and Professor Owalabi touched on it, is we and GBD, we had a lot of discussions early on. If we don't have enough data or adequate data for a condition, should we release a number for it? Like in Nigeria, for example, we don't have enough data to get a good estimate of rheumatic heart fever. Should we do it or not? And the decision, and we had ethical discussions, was like, you should. Otherwise, what are you telling the world? That that's not a problem in Nigeria? You have to. And you pay for it by having a wider confidence interval. So there is a pressure on us to release a number because we need to treat everybody equitably across the world and point to a problem and lack of data at the same time. So that's a problem. That's our best estimate. We have a wide confidence interval because we don't have adequate data for it in that location. That's very important. The second one about data development in Africa. It's simply supply and demand. I mean, let's be honest about it. And there is a demand on data from like IHME and others, but that's not the right demand. The right demand for data has to be capacity at the local government to do collection and data analysis. And right now, Dr. Mensah knows, I've been collecting data. I run a large survey in the US. If people come to me right now and say, Ali, I'll pay you to do a survey in one place, I say, and I'll pay you to collect the data. I say, thank you. I want money to analyze the data, publish report, train people at the local level to keep that capacity in that country. So what Africa can do, and where I come from in the Middle East, is elevate that level within the Ministry of Health or within a National Statistical Bureau. So give them credibility, give them visibility, create that capacity to collect the data and analyze it and publish it. And once you promote the utility of that data, then there'll be more money to collect the data because every politician, every policymaker would need the update of that data. But until we do it that way, we go look at it backward, create the capacity for analysis and collection and utility and use of the data and publicity of the data. We should invest on it first. Then we go back and say, let's collect the data that we need. And of course, I agree with Professor Anna that now technology allows us to do it much better and we should look into technology. Over.
Dr. Williams, could I chime in a quick follow-up to Professor Makdad? This has really been fantastic. So thank you all. Now, if there's someone in the audience who's already started thinking of the research they're going to do, and they really want to use the local level data, they want to use the global burden, the assessments for Africa, what is the best single link they can go to? That's one. And also, if you can put in the chat for us, what is the way for them to become a collaborator from their country, right? So they want to be a collaborator of this network, but they also want to immediately get to some of your data so they can start writing their research application to NIH. The point is that the University of Washington, the Global Burden of Disease effort, which has all the collaborators around the world, have remarkable resources for you. So don't think this is too daunting. Anything you need, these guys are here. They will be willing to help, and look for the link that we will send to all of you later. Thank you.
So hopefully you all see the link. Professor Dwyer-Lingram just put it in the chat, http://www.healthdata.org-gbd/call for collaborators. I may be saying that incorrectly, but if you go to healthdata.org, there is a link, and Professor Makdad just added another link, /GBD-compare. So those two links will be very helpful in reference to the question that Dr. Mensah just asked.
Outstanding. Thank you.
So with that, I'm just going to close this portion of our session, again saying thank you to our speakers for such great presentations, and just want to highlight at least one major thing that at least I heard from each of the presentations. So Professor Makdad highlighted that the burden of disease is changing in Africa, but there's still this unfinished business with dealing with infectious diseases. And the burden of disease shows that the non-communicable diseases will pose a challenge as we are still dealing with infectious diseases. The other thing that came up was from Professor Laura Dwyer-Lingram's presentation, was that the health burden varies often dramatically within the country. So we need to think about ways to quantify and understand how the burden of disease varies locally in order to enable identifying local conditions and priorities, as well as inequalities that are really important and need to be addressed. And then we heard from Professor Mukungi, who gave the example of rheumatic heart disease, which is a very important condition that is across the lifespan and determines a high burden of disease in Africa. And there's still some major gaps in understanding susceptibility, pathogenesis, and natural history of rheumatic heart disease. So innovation in research and the use of data is really needed in order to increase knowledge and to improve care and inform policy. And then finally, we ended with Professor Olabi, who really made the point of how harnessing mobile technologies for surveillance and interventions for stroke, CVD, and other NCDs within Africa is very key. So I hope that you all really enjoyed hearing these different presentations. And what I'm going to do now is turn it over back to...
Sorry, Professor Makida, Dr. Makida. We need to remember, I like this presenter. I'm talking too much because I'm really enjoying this, and thank you for the organization. But COVID-19 will set us back, especially in Africa. And in our data collection and our planning, we need to figure out what's the impact and what's the best way to go back on track as fast as we can. So all what we are discussing right now is becoming more of priority, as COVID-19 is going to delay us and reduce some of the gains that we have achieved in infectious disease, and will increase, unfortunately, non-communicable disease. So keep in mind, all people who are listening, that our data collection, our activities right now is to make sure we know what's the impact and how we can address it to go back on the right track. Over. Sorry to interrupt.
No,
Dr. Williams, since you allowed him to interject, may I also interject for a minute, please? That sounded to me like an invitation to say that if you've been thinking of how we use our experience in HIV and malaria and TB to address COVID-19 as we prepare our data science efforts for future pandemics, that sounds like he's inviting you to reach out to him and be a collaborator and work with him on it. So that's fantastic. So thank you.
No, and that's actually all I had to say. And that was a great point to end with, because that is something that we're currently dealing with, and it will have a great, great impact. So thank you so much, Professor Makdad, for adding that piece. Now I will go ahead and turn it over to Maggie to take us to the next phase of our session. Thank you so much again.
Absolutely. Thank you, Makeda and George and all the panelists for really a very interesting and compelling discussion. I'm going to ask those panelists and moderators to please now go and prepare the breakout rooms for the interactive session that's upcoming. For the rest of you, we will invite you in a moment to join them, but you'll be able to continue the conversation with them after I tell you a few things. So first of all, in the chat, you will very soon see a link to a feedback survey that we would really appreciate if you would take some time to fill it out. We really value your feedback. It helps us learn if this was useful to you. So I'm going to just give you a few moments. It shouldn't take more than 10 or 15 seconds if you could click through and just let us know how you felt about today's session. And then again, I'm asking the panelists and the moderators, you are welcome to leave us and go get those breakout rooms ready so that when the rest of the attendees come to join you and continue the conversation, you will be there waiting for them. So yes, thank you again for filling out the survey. Really appreciate that. Your feedback is interesting to us. We want to know what you thought about it all. Let's see, what's coming up next? As Amit said earlier today, this is the last in the series of webinars in the State of Data Science series. However, do keep a note, kind of keep Tuesday, December 15th clear, because there'll be a landscaping workshop where we'll do some summary and make some bridges to the next part of this whole project. More details will be coming soon about how you can register and what that's all about, just to keep that in your mind. And you can come back to ChiStorm and find out more about it, or there will be messages coming to you from the NIH to keep you informed and updated. Like we promised, there is an interactive session coming up very soon. That's actually now. Let me tell you how to get there. When we close this webinar, there'll be a red button at the bottom of your screen and you can leave, and it should take you back to ChiStorm. And this is the page right here, this October 21st page that you probably were on in order to get to this meeting. It looks something like this right here. And if you will go back to that page, scroll down, because auto-magically 3 Post-it notes have appeared and they look like this. And they have 2 different sessions that you could attend where you could convene with other panelists, with the panelists and other participants to continue the discussion. And I'll show you, they'll be at the bottom of the page there. There's also a tech help desk. If you have any questions, you can go there. But otherwise, welcome to join one of those sessions. And with that, I think all I want to say to you is thank you very much for joining us for this interesting panel. I hope you'll stay with us and come to the interactive sessions and keep going, dive deep with our panelists. And thank you very much. Have a good afternoon or a good day wherever you are.